Please start, sir. We are live.
Very good evening to everyone. I am Dr. Jan Prajapati on behalf of Aris Life Sciences. Welcome you all in our today's scientific event, that is part 8, we can say, of Krevas Academic. Krevas Academic, that journey was started, we can say, a few months back on April month with our first event. Why we are conducting this Krevas Academic? Because you all know that Aris is number one company in patient care initiatives. And we are always looking for improving the health outcome of our cardiometabolic patients. So our service is also in that direction. And we are offering the patient care initiatives program and service to our patients for benefit of their health outcome, especially they are suffering from cardiometabolic disease. And this our initiatives that range from ABPM on call, sleep studies, Halter on call, CGM on call, and so many other our initiatives which are ultimately helping our cardiometabolic patients in improving health outcome. On that direction, we also started our scientific platform, a unique scientific platform which calls Krevas Academic, which educate our clinicians, our physicians, especially for improving the patient outcome. So not only patient care initiatives, but scientific platform that also help our clinicians, especially across India, to improving the patient outcome when they are managing or they are dealing with cardiometabolic patients. So this is a round the year event that we are conducting at the Krevas Academic, and the ultimately objective is to disseminate the science for improving the better outcome of the cardiometabolic patient, and that is the main objective of Krevas Academic. So as I mentioned, the journey started in the month of April, where we conducted our first session with our eminent speakers and the moderators on statins, the essential for diabetic heart. So that followed by, so we got the tremendous response from this first session on that was in the month of April on Krevas Academic. And that series now further the journey started, and that started with this with second session on May on the statin optimization, the need of the hour, because we all know that the optimization of statin is prime important now for our cardiometabolic patient for providing that protection against the cardiovascular events. So that was again conducted with our eminent speakers of this second session. That was followed by the third session on the month of June, where the session was on the battle against the arterial plaque with statin therapy. So that particularly very important session where we talk about the plaque stabilization, even the prevention of the primary and secondary events in the patient with the help of statin therapy. And that was again, we had eminent speaker in that session 3 that was conducted in the month of June. Followed by the fourth session. So this is a series of the sessions. The fourth session on month of July, and that was again a very important session on the statin-induced muscle symptoms. So the jury on SAMS, I think, and that was again wonderful session conducted by the eminent speaker under the guidance of our moderator, Dr. Sanjeev Shah. The fifth one that was conducted on the month of August, and that was the hidden threat, low LDL yet high CV risk. Again, very important session that was conducted because the patients having the normal LDL, but still they are at high CV risk. So what are the hidden factors or the threat was that, and that was the discuss with eminent speakers and the moderator in that particular session. So this all journey towards the learning of the patients, how to treat the patients under the Krevas Academic. Followed by the sixth session on the month of September, where we are emphasize on the high intensity statin therapy for cardiovascular disease management. And that was again a very unique session and a great learning about the importance of the high intensity statin therapy when we consider the patient body cardiovascular disease management. That was followed by the session number 7 in the month of October, and that was on intensity matters, the deciphering its significance in the statin therapy. So that was again emphasized the statin therapy to be used in each and every eligible patient at possible intensity for the cardiovascular disease management. So this was the, we can say, the journey that of the Krevas Academic till date that was started in the month of April, and we are promised to deliver this particular scientific feast each and every month under the Krevas academic event to our clinicians, educating them about the use of the statin therapy for management of the cardiometabolic disorder. So today we are going to discuss about our session 8 in the month of December, and this is a unique again. We can take kind of the puzzle. So that was the name is given the unraveling the lipid puzzle, the holistic approach to dyslipidemia management. So here again we are going to discuss with this unique session, and for this session we have a speakers and moderator with us. I would like to welcome Dr. Sanjeev Shah, who is a moderator for this today's event. And we all know we are introducing them multiple times on the earlier 7 sessions. And you all now well aware about our moderator, who is a expert, and we can say in this field of this diabetes. And currently is practicing at Nanavati Max Super Specialty Hospital at Mumbai, and having the academic relation in private practice since last 40 years. So I would like to invite Dr. Sanjeev Shah to carry forward this session and give us the in-depth idea about now session number 8 on the lipid management. So over to you, Dr. Shah.
Thank you, Dr. Hiren. And may I have the next slide, please? So today's topic is slightly different and unusual. If you look at the theme of all the topic 7 session you have listened to, we have focused heavily on the most culprit, total cholesterol, which is synonymous with LDL cholesterol. At the same time, our focus had been to highlight the importance of high-intensity statin rather than a low-intensity statin. Our practice in India and all over the world, even in high-risk population, is to prescribe the low-intensity statin. And we keep patients deprived of real benefit of high-intensity statin, 50% reduction in LDL, which is desirable, and going as low as possible. This time we have diverted our topic on a theme-based. Our first topic will still continue to be decoding a lipid profile, but we have kept a small summary of checking on triglyceride and what's the impact of lowering triglyceride on cardiovascular health and outcome. Our third speaker is going to be Dr. Usha Ayagiri, who is going to talk about nutritional intervention in dyslipidemia. Our patients believe that nutrition is going to make a difference and they don't want to take a statin. They want to normalize the lipid profile using a nutritional modification. So she is going to decode the benefits and limitations of nutritional intervention. But we have not deviated from our topic, and we have kept and invited Dr. Muralidharan, who was also part of our second session earlier in the month of May. He is going to talk on the very, very important basics on LDL versus HDL versus triglyceride, what matters more in relation to cardiovascular disease. Dr. Hiren, the next slide, please. And for that, Dr. Muralidharan is head of the department and director of Cath Lab at Sri Ramchandra Institute of Higher Education in Chennai City. He had been a president of Cardiology Society Chennai chapter, electrophysiologist, 49 publication in Index Journal, had been organized multiple conferences over the years, have received many awards, principal investigator in many trials, best doctor award, and delivered multiple lectures as a key opinion leader. But Dr. Muralidharan is going to highlight on the basics of lipid profile. Though we have touched upon non-HDL in one of our sessions, we have touched on apolipoprotein in one of the sessions. We have kept a LPA for the future meeting, but today he is going to talk us on basic, simple lipid profile we ask laboratory to carry out. Over to you, Dr. Muralidharan. Thank you, Dr. Hiren.
Thank you. Thank you very much, sir. Thank you, Dr. Sanjeev, for the kind words about me. Allow me to share the screen. Thank you to Aries and Kravas Academy for two things. One is inviting me today and inviting for the 8th session, because you would have made our audience well versed with what we are going to discuss, what we are going to do. So you have made my job also simple. As Dr. Sanjeev rightly said, I am supposed to talk on the basics of it to a very, very learned audience in this group. I'm lucky. That's one thing I would like to say. And let me start my talk here. Decoding lipid profile. Is it like a low density lipoprotein with a high density lipoprotein, or a triglyceride? What matters most? I know by seeing today the agenda, I'm going to setting the tone in a strong way. So there'll be panel discussion, and my esteemed colleagues are going to discuss about these factors in detail. So to come into this thing, classify lipids and their involvement or influence in atherosclerotic cardiovascular disease, we have lipids which are enhancers of CVDs, like triglyceride, lipoprotein little a, LDL, VLDL, IDL, trans fat, phosphatidylcholine, or lysophosphatidic acid. Though we use the term enhancers, many of us have agreed for the last decade that LDL has been almost given as a causal role in atherosclerotic disease. We do have conditionally impact on CVDs like lipids like fatty acid, phospholipids, HDL, or sphingosine, and not a known effects for several other lipids, where maybe the future may reveal their protective or destructive influence. Looking at the types of lipoproteins and other things, few things are important, like today's topic, like chylomicrons, which are rich in triglycerides or VLDL, are coming to low density lipoprotein or high density lipoprotein. We started looking at in a various ways, looking at their values and their importance, but to treat in a simple way, chylomicron useful to take the cholesterol, dietary exogenous cholesterol to the intestine, to the tissue, because we know fat is not soluble in water. So these lipoproteins going to help them to get transported well. And when you come to VLDL, they take endogenous, and contrary to chylomicron exogenous, endogenous core substance the liver to the tissues. And IDL, again, endogenous core substance the liver to the tissues. And LDL, important thing, takes endogenous core substance the liver to the tissues, sometimes in a very high, rapid sequence or rapid rate to cause abnormalities. Then comes our HDL, the reverse cholesterol transport, where it takes endogenous cholesterol from the tissues to the liver. And to look at the LDL, as I said, it has become a causal agent in atherosclerosis. When LDL particles, I hope I can get my laser pointer. Yeah. So in LDL particles, when they cross the vessel lumen, go into the subendothelial, in the intima, they undergo so many changes. Importantly, like oxidative stress by various enzymes one side. It can go for enzymatic modification, and it can be the enzyme modified LDL can become a cholesterol ester or foam cell rich aggregates, and other side the monocyte derived macrophages can have influence. All these things lead to two things: pro-inflammatory or pro-thrombotic phenotype, and cholesterol ester and cholesterol crystal rich necrotic core, like how it influences the atheroma, not to forget the foam cell. So the beginning point is the LDL particle moving into the subendothelial intimal region to start the whole thing. Coming next to looking at the atherobiology, as we said, as it enters the arterial endothelium, the smooth muscle derived extracellular matrix or the oxidative stress, as we discussed just now, going to make the intimate LDL to get retained and accumulation, which gets modified. Circulatory macrophages coming in, and macrophages with the pro-inflammatory, pro-thrombogenic phenotype, leading to formation of foam cell, leading to plaque progression. In this plaque progression, two things we see. There are pro-inflammatory mediator, or fibrous thinning, cellular necrosis, or matrix metalloproteinase, all these things. There are some protective things which fails often, like efferocytosis, very interesting systems which are protective, pro-resolve mediators and all, which do work, but when the pro-inflammatory things becomes a dominant one, you get unstable advanced plaque, lead to plaque rupture, thrombus, and a clinical event, what we call acute coronary syndrome, or it can remain as a stable plaque. This is in a nutshell the atherobiology, or the way it starts with the influence of various other factors and enzymes. And looking at the epidemiology, looking at the pathophysiology at a molecular level, looking at the epidemiology, we know LDL cholesterol exhibits a linear relationship with the incidence of disease, doubling our risk per unit increase. What we are seeing is in 1 millimole, to convert to millimole to milligram. Like India, we practice only milligrams in cholesterol. Very simple. Any non-HDL cholesterol or LDL cholesterol multiply by 38.67 or ECG multiply by 38. So 1 millimole is equal to 38 milligram. That is a simple conversion formula. So if the increase as the LDL level or non-HDL cholesterol increases, the disease doubles. The risk of ASCVD doubles, which is very well known by various studies. And as they increase and as we get old, the risk of both myocardial infarction or atherosclerotic cardiovascular disease increases with a rise in LDL by 1 millimole or 38 milligram. And CTT trial, largest one, where the conclusion was the size of the reduction has a significant influence on the reduction in the coronary event or vascular event. Each 1 millimole LDL reduction, really 1/5, around 20 or to be precise, 22% reduction of vascular events has been reported by various trials, which we will see very quickly, and reduce the risk overall by 40 to 50%. As I said, 38.67, for convenience, it has been quoted as 39 milligram. And these are the various major trials, landmark trials, both secondary prevention shown in the square, orange square, or a gray diamond shape, like comparing the placebo versus active part. All the trials have shown lower the cholesterol better, both in primary prevention and in secondary prevention. Each of these trials are the learning material, how to do a study also. A well-planned trial, very well done. Everything has shown very important influence of LDL cholesterol. That is where we proved the role of LDL cholesterol in causation of cardiovascular disease. And you have seen so many sessions so far where it has caused a significant influence on it. What is the residual risk? Because unlike other diseases like typhoid or malaria, where you kill the mosquito or you kill the plasmodium, the disease fails to cease to exist, there is a lot of residual risk. Even if you make the whole world lipidemic, the CAD is not going to disappear. That's the important thing. So residual risk is defined as the risk of CV even that persists in people despite achieving not only good cholesterol, ideal LDL cholesterol, but optimal blood pressure and glycemia according to current standard of care. That is one important thing. Even today in our practice, we see around 25% of patients who come with atherosclerotic cardiovascular disease, they do not have a defined abnormal risk factor. That is the one thing we see. So CV even still occur despite statin therapy, which is a cornerstone of dyslipidemia management. And an atherogenic lipid profile, we all know it is a combo situation where low level of HDL, high level of LDL or IDL, triglycerides, lipoprotein literally or non-HDL are all found in metabolic syndrome and diabetes mellitus. And the residual risk remains in patients with diabetes to statin, triglyceride is one of those risk factors. So one side, I have reduced the optimal LDL level, one of the risk factors you can see by HPS trial where they use simvastatin or CARS trial where they use atorvastatin, you have 68% residual risk or 78% residual risk. This is one thing which challenges the medical community, challenges the mankind. We should keep seeking ways how to prevent it. One other target which we may discuss today is like what to do with the triglyceride. We know there are studies have shown relationship between triglyceride and cardiovascular risk in two large trials like DAL outcomes and miracle studies. As we see here, we see in both the trials, as the level of triglyceride goes up, the risk of coronary event goes up. So we knew some of the studies. Of course, we can discuss about what happened to various studies, meta-analysis, what the guidelines say a little later. So there is an association of triglyceride, seems to be strong in this study with residual risk after ACS in patients receiving effective statin therapy. What about mortality? Coming to the bezafibrate infarction prevention study, elevated triglyceride level are independently associated with increased all-cause mortality in patients with established coronary artery disease. We saw that in various groups, like from TGL, triglyceride below 100 to triglyceride above 500, as the level goes up, the risk of death is going up in this group. This 22-year mortality is for patients severe hypertriglyceridemia has increased by 68% when compared to patients with low normal triglycerides. So last thing I'm going to do before concluding my talk is look at HDL, Indian phenotype. We know so much of discussion, so many studies have been done on high-density lipoprotein cholesterol, its role in reverse transport, and its role, whether the number or the activity, everything. But one thing very different in our country is, with all the studies done in India, we are prone to have low HDL as a race. Compared with LDLC, HDLC is of secondary importance for CV risk stratification, and calculation of LDLC HDLC ratio is not that useful. We stopped following those. Several labs are giving that ratio. We stopped following it rather than we look at the number or we write. Maybe we can discuss. Increase in HDL-C through lifestyle changes has positive effects and is recommended. We know that. But at the same time, we all know the original trials or original studies like HDL Milano, seen in an Italian village where protective against atherogenesis, the people had in 2 digits, I mean, less than 20, their HDL was. So whether low HDL or high HDL or HDL activity going to cause, I will wait for my esteemed colleagues to give me a new enlightening on these things. And among the drugs, several drugs have come but not approved because of the various trial results. Rosuvastatin and niacin increases more HDL than atorvastatin. That is one thing we know. So the take-home message is LDL cholesterol is a major component. A linear association seen with the level of cholesterol and the risk of CAD or the ASCVD. And the triglyceride, while reducing trials like strength and prominent and reduced have shown inconsistent results over MACE reduction. That we'll reserve it for our discussion. And LDL-C, as I said, is established as an atherogenic biomarker or even a causal trait. I'll stop here and I will wait for my panel to come in and discuss the same.
Thank you, Dr. Muralidharan, for highlighting in just 10 minutes time. Now we have about 6 minutes for discussion. First, I'll ask a question to Dr. Usha, and then I have one important practical question for you, Dr. Muralidharan. So, Dr. Usha, are you live here?
I'm right here.
Yeah, we can't see you, so I thought.
No, right
Dr.
here.
Usha, in your diabetology practice as a diabetologist, what kind of a target? When a patient develops coronary artery disease, he is partly in the hands of cardiologist. Cardiologist has decided and prescribed all secondary prevention program. But before a patient lands up with a cardiologist, he is in the clinic of diabetologist and consulting physicians. So what kind of a target you keep in mind when you prescribe lipid-lowering therapy in high-risk diabetes individuals? Diabetic patients are truly high-risk patients. All of us know that. We have had discussion a couple of times in the previous meeting. So tell us what kind of a target.
So in people with diabetes who have no CVD history and who have no other risk factors. So if they don't have diabetes or a second risk factor, then I would be aiming for an LDL of at least under 100. However, having said that, if there is any additional risk factor, then I think we should be aiming for an LDL under 70. If they've had a cardiac event, or if they come under the very high risk group, as I'm sure Dr. Muralidharan will support, I think we should be aiming even lower down to potentially 50 or as low as we can go. But I think we all acknowledge that in clinical practice, how frequently do we actually achieve these levels is the million-dollar question.
But Dr. Usha, we do prescribe the low intensity and we leave it there 5 milligram and 10 milligram. Half of the patients are still on atorvastatin 10 milligram, which does not take them to a goal. For that, I have some important question for Dr. Muralidharan. Dr. Muralidharan, lab people put up a so-called up to 200 as a normal total cholesterol. And many times I have seen that if TC is 190, all these people with HDL and triglyceride are in the range of 150 to 200 will have eventually an LDL of 110, which in the lab report looks like a I am very close to normal. So how do you see the change from 110 to 80 with some dose of a statin versus 110 to 60, which is close to 50% reduction? The first one is a 30% reduction. Second is a 50% reduction. So how do you make a decision, especially in primary prevention? In secondary, you will go more aggressive. We want a large many internal medicine people to prescribe what should be the right dose and what should be the right target.
Yes, sir. Thank you, sir. This is a problem like you took me back to 80s when I was a medical student. That time people say the normal cholesterol can be about up to 250. Over time, things were slowly moving to different ranges. We saw different targets. But today we know, as Dr. Usha put the points, we aim for below 100, below 70, below 50, or much less than that. Sometimes even lipid also in India recommend up to 30 milligram. What I do in my practice is we look at the risk score. That's what we are looking for. Secondary prevention, we are very, very aggressive, going to less than 70, prefer to reach 50 milligram. In primary prevention, we spend time, we look at the patient's overall metabolic milieu, or looking at the risk profile. If the profile is bad, I generally, in my practice, I educate the patient to go to 70. As Dr. Usha said, when I say 70, many times I reach 80 or 90. When I say 100, I don't reach even 100 at all. That is a
Right.
practical problem. We keep escalating the statin also. And thanks to the media and WhatsApp, which scared our patients a lot, they ask so many questions. We may have to have patience and explain to them. Over time, we achieve it. That's what I have been doing. So I aim for below 100. Many times in my patients with a high cardiac risk score, I go for below 70. And my the tendency or threshold to use high dose statin is very, very low.
Can I
Thank you,
just
Dr.
come in on
Muralidharan.
this briefly?
Yeah,
Can I just come in on this briefly?
yes.
So, when you just said the lab people give 200 as a reference point. Well, actually, we know from epidemiological studies that in free living primates, not human beings, but in free living primates, apes, great apes with whom we share a lot of biology, the LDL level is about 60 to 80, sometimes as low as 40. So 40 to 60 to 80. And I think these normative data for populations, which have been established within the last 30, 40 years after our diet and our lifestyles changed significantly, may in themselves be biased. And I don't know, Dr. Muralidharan, whether actually accepting the current normative data is ideal for us from a cardiovascular health point of view.
Dr. Usha, would you prescribe the fibrate first or a statin first if a people have, let's say, 220 triglyceride and you have 120 LDL? You have to select between one of a lipid lowering agent. How do you make a selection?
I would still prescribe a statin first, because even for triglycerides, statins are still the single most effective triglyceride lowering agent. And if the triglyceride lowering is suboptimal, and then we have to think exactly what target we're trying to achieve and why, and whether we are doing this from a pancreatitis point of view or whether we are trying to minimize cardiovascular risk, which is again something I'm sure the next speaker is going to discuss. But the first drug of choice for me is still and will always remain a statin with a fibrate in addition in certain limited situations.
So thank you, Dr. Usha. We would continue the discussion on triglyceride as we finish next talk, which is by me. And if I go to the first slide. So I'm going to talk about impact of lowering triglyceride on cardiovascular health. This is the European Atherosclerosis Society, who believes that therapeutic targeting triglyceride below 150 is important. Low HDL may provide further benefit. All of you must be aware that a triglyceride upon HDL ratio, if more than 5, is an indirect indicator of insulin resistance. And the guidelines recommend considering treatment for high triglyceride when triglyceride is more than 203 milligram per deciliter. So let's examine where is the association of triglyceride. First is a myocardial infarction and a CV outcome shown by partly Dr. Muralidharan. I am going to show you a couple of more papers in relation to coronary artery disease and a triglyceride. Pancreatitis is well known with triglyceride level more than 500, and many patients with hypertriglyceridemia will have some level of fatty liver stage 1, 2, or may advanced inflammatory NASH or an advanced cirrhosis. Because our Southeast Asian phenotype is typically with a high waistline with visceral fat, high insulin resistance, associated with higher inflammatory markers, abnormal lipid profile, and association with all abnormality is in glucose metabolism. One of the study carried out with by ICMR looked at kind of a dyslipidemia prevalent in our population, and that showed that more than 70% of people had low HDL and 30% had high triglyceride. And this is what has now resulted into diabetic people, most with metabolic syndrome, will have atherogenic diabetic dyslipidemia and will have all these three abnormalities: high TG more than 150 in many people, low HDL in large majority, and LDL above recommended target of 100 milligram. If we look at a couple of studies on triglyceride and HDL with risk of coronary heart disease, as well as in this paper published in Diabetes Care in diabetic population for ischemic stroke. This is a study with more than 3,000 American Indians. So I have selected only Indians here, free of a cardiovascular disease at baseline, followed up for 17 years. And if you see, on the left is no diabetes, on the right is diabetes, and you look at coronary heart disease in the top, ischemic stroke in the bottom line, and triglyceride and low HDL in diabetic population had higher risk, 1.54 as a hazard ratio and 1.82 in for ischemic stroke. In another paper, in type 2 diabetic patients, again from US, with a duration from 2010 to 2016, all the patients were on statin therapy, with LDL being achieved below 100 at that time point, were divided into two categories: triglyceride between 200 to 500, 5,000 patients; normal triglyceride less than 150, 22,000 patients. So this makes roughly 80% of the people, and CV events were followed at the end. And you can see distinctly a difference in the group between triglyceride 200 to 500 versus triglyceride less than 150. Non-fatal MI was higher, non-fatal stroke was higher, unstable angina, coronary revascularization rate, except mortality, all CV endpoints were higher in the people who had triglyceride higher. So in spite of statin, if people have higher triglyceride, this is what probably contributes an additional residual risk. This is what Dr. Muralidharan was talking about, the residual risk. But we have to also remember, in our population who have been prescribed low or moderate intensity statin, our LDL is not at the goal, then we are allowing additional element of residual risk by simply not achieving or reducing LDL by 50%. So despite statin controlled LDL, CV events were higher in patients who had not achieved triglyceride at target. There is a complex relationship between a triglyceride and increased coronary heart disease, probably is related to low HDL level, highly atherogenic forms of LDL cholesterol. So it's not the number, but the quality of LDL cholesterol might matter. The contribution of insulin resistance, inflammation associated with that might have atherosclerosis being more advanced irrespective of LDL level. As we know that a metabolic syndrome is associated with higher procoagulation state, higher thrombogenicity, and slightly uncontrolled level of hypertension and visceral obesity as a part of metabolic syndrome. If we see the standard ATP3 guidelines on diagnosis of metabolic syndrome, large majority of diabetic patients with triglyceride more than 150 will have invariably HDL low, higher waistline, glucose abnormality, hypertension in 70% of diabetic patients. People will qualify to be having metabolic syndrome associated with diabetes. Coming to the different interventional trial in triglyceride, the first of all was a field trial done close to 10,000 patients, fenofibrate versus placebo. When this trial was carried out, there was no statin as a baseline in all these patients. Only fenofibrate was used against placebo, and they looked at all cardiovascular endpoints. If you see the finding, there had been a small benefit in couple of primary endpoints, but no benefit in cardiovascular endpoints and mortality. Field trial was considered to be a negative cardiovascular outcome trial. Everyone interpreted that lowering triglyceride would not result into lower endpoints. Probably the difference was many patients in the placebo group received a statin as a part of a baseline, though there was no statin, but a statin was introduced when the trial was ongoing, looking at the lipid profile level. But if we see the benefit, there was a benefit in retinopathy in patients who were treated with fenofibrate. There was a benefit in relation to albuminuria, which has received larger attention these days in the definition of kidney disease in diabetic population. So fenofibrate would reduce triglyceride, increase HDL, reduce LDL by 20% arbitrarily. At the same time, will reduce the level of atherogenic small dense LDL. This is all would happen because it is a PPAR agonist molecule, will increase the activity of lipoprotein lipase, reduce hepatic fatty acid synthesis. Similar molecules have been evaluated and are used in a fatty liver disease. This also increases the production of ApoA1. There are also non-lipid lowering properties with fenofibrate, that is reducing uric acid level, reduce cytokine and PI1 level. It has partial antioxidant activity, some inhibition of platelet aggregation, and in some people, it would also improve insulin sensitivity. Looking at another important trial, which is a prominent trial, if you look at this particular trial, you can see clearly the conclusion that reduction in triglyceride does not decrease the CV event. Though pemafibrate lowered the triglyceride, you can clearly see the non-fatal MI and ischemic stroke and revascularization, exactly identical event in both pemafibrate and placebo group. This was done with a background statin being used in all these people. If we look at the meta-analysis of 5 different studies, 4,000 patients triglyceride when it was prescribed when level was more than 200 milligram. These are different trials done for different results, different population. You can see Accord, Field, VAHIT studies, and you find a small benefit in favor of reducing triglyceride on the left side, TG more than 204, HDL less than 34. Please remember, look at the level. HDL was grossly low in all these people in comparison to the right, which was triglyceride less than 204, HDL more than 34. So 35% relative risk reduction with a triglyceride lowering in patients with this kind of a lipid profile. This is again inconsistent result on MACE reduction. 3 different studies published by Dr. Deepak Bhatt recently on reduce IT, beneficial effect, strength study stopped due to no futility, and prominent trial was negative. So this is a very latest 2023 European Heart Journal publication. They looked at 3 different trials and all 3 different findings. No benefit, trial stopped due to no benefit, and the beneficial studies. So what do we learn from all these studies? Reducing triglyceride is equally important. So I have put up what Dr. Usha earlier answered, that what is an impact of statin on lowering of triglyceride. So it is likely that triglyceride may go down by approximately 20% in many patients with a different statin dose. But the statin will have, in addition to reduction in triglyceride, there would be a pleiotropic effect, and that cannot be matched by any other class of a drug like fibrates, ezetimibe, or bempedoic acid, like improving endothelial function, stability of plaque, reducing oxidative stress, reducing vascular inflammation, high sensitivity CRP, and probable anti-thrombotic effects. With this, I would end here and we would move into the panel discussion. Again, in next 5 minutes, I have got 2 questions for our 2 experts. So I have a first slide for Dr. Usha. So in your diabetology practice, do we need to treat high triglyceride? At what level you combine? As you said, you will initiate statin first. You very frequently add fenofibrate in a combination with statin. In Indian market, we have both atorvastatin and rosuvastatin available with fenofibrate. And what is your opinion on how triglyceride is detrimental? It's beyond doubt that more than 500 can precipitate pancreatitis in diabetic population. Dr. Usha, please.
Thank you very much, Dr. Shah. So, for me, triglyceride, the level of triglyceride is not just an absolute number in itself, but more a marker, if you will, of their metabolic health. Because quite frequently in the diabetes practice, a high triglyceride level is associated with poor glycemic control. So to me, the triglyceride is a reflection of their glycemic control, of their metabolic risk, and of their risk for metabolic syndrome. And no, it's not a benign condition, because when you look at a high triglyceride, you look at it in the setting of an Asian phenotype with a high triglyceride, a high waist circumference, a low HDLC, and dysglycemia frequently, as an entirety of a cardiovascular metabolic risk spectrum. High triglyceride, now the cardiovascular side of things, I'm sure Dr. Muralidharan is better qualified than me to talk about, but certainly at a level above 500, as you've said, the primary risk I perceive is of pancreatitis. And certainly at that kind of a level, if dysglycemia is also a concern, statin along with insulin plus or minus a fibrate would be my go-to. At that kind of a level, I'd probably put in a combination therapy with a statin and a fibrate, and then add in some insulin, which will definitely help control the glucose levels and therefore indirectly the triglyceride levels. If it is less than 500, let's say above 300 but less than 500, arbitrary, but what we use in clinical practice kind of levels, I might still start with the statin first, because I expect to see, certainly with a good high-dose atorvastatin or a medium-dose rosuvastatin, a 20 or higher plus % reduction in triglycerides, which would bring them down to a manageable level for me, side by side with managing their glycemia. So the, combination of glycemic control with a statin and potentially a fibrate, if it's at the higher end of normal, would be enough. But I would certainly agree that at the very high levels, triglyceride has the potential for pancreatitis and adverse cardiometabolic health as a marker. But at the lower levels, how aggressively do we need to treat, and do we really need to lower it to less than 150? And what the cardiovascular benefits of consistently lowering to less than 150 are something that I think we need to discuss.
Thank you, Dr. Usha. Dr. Muralidharan, I have a slight tricky question for you. The triglyceride talk cannot be completed without some words on omega-3. So I'm going to show you the slide which summarizes findings from the studies. So you will take one by one and tell the listeners what kind of a wisdom and a message out of these studies, which you will see now, which you have not seen earlier, the slide and the study. And at the end, you will put your comment in relation to fenofibrate in combination with a statin. When do you use, which was partly answered by Dr. Usha, if you have to add anything on that. So let's look at the next slide. This is unclear benefits on CVD health from some omega-3 PUFA clinical trials. You can take one after another. There are 4 of them, 3 bullet points.
Yeah.
You can read together when people are also reading together.
Reduced study is a recent large ASCVD outcome study of an EPA only, that is icosapentaenoic acid, at high dose of 4 grams per day. Reduction in ASCVD events for patients on statin was shown.
Dr. Deepak Bhatt's publication.
Yeah. Pardon, sir?
Deepak Bhatt's published and popular.
Yeah. In contrast to a low dose prescription omega-3 1 gram, failed to show benefit over 40,000 patients in PN, Ascend and Vital. Another high dose study, strength that used omega-3 PUFA with EPA or DHA has been halted because of lack of any apparent benefits. To put it in my practice, sir, this has been happening to us for the last 15-20 years. Like molecules come, particularly PUFA or omega-3 fatty acids, and the use of it in things, though they look attractive and as you nicely elucidated how they have a better mechanistic effect and the trials and the reduction. As a cardiologist or as a guideline forming committee, not me, both the European and American Society, when they looked into the outcome was never that robust. That's the problem we face. So, do I use it routinely? Honest answer is no. I don't use for this omega-3 fatty acid routinely in my practice. Maybe rarest of rare. We will talk about the guideline. Maybe some more trial do I have to see, sir? Shall I give the comment at the end? Is there any other trial?
No, this is the last slide for you.
Okay.
There is nothing more.
Yeah. So based on this and the meta-analysis we have seen the triglyceride, everything, the usage of fenofibrate. I used to use a lot of gem fibrosis 20 years back. Now it is not available. Flofibrate not available. Commonest is fenofibrate in our country. Bezafibrate rarely available. What I do is, if my patient are having a high risk, number 1, already on statin, number 2, and having the persistent high triglyceride level above 200 despite optimal control of diabetes, I have a tendency to add fenofibrate in my practice. There are combinations available which I have used very frequently, but that is what my aim. Why I am doing it, I would love to use it more and more frequently, but every guideline giving me a status of class 2B. I am looking for new papers, new studies, strong association, so that at least it went 2A. Till now, the latest is 2021, I think, European guidelines. American guideline is 2018. All of them have given the role for 2B status only, the level of class of recommendation. So I do use infrequently, sir.
Thank you, Dr. Muralidharan. So fenofibrate is far more easier. I have a difficulty of getting full adherence and compliance with statin itself. Prescribing a high dose, multiple capsules, expensive in a diabetic prescription with huge list of a drug is very, very difficult. Thank you, Dr. Muralidharan. So we move on to the next talk, which is the third talk of the day. I welcome Dr. Usha Ayagiri, who is trained in diabetes endocrinology at Oxford University, UK. She is honorary professor in Tamil Nadu MGR University. She is a consultant endocrinologist at Apollo Sugar Clinic and Apollo Specialty Hospital, Apollo Cancer Hospital. Today, both the experts are from Chennai. 22 years experience, academic, has delivered many lectures and orations, and part of the many CME programs with me. Over to you, Dr. Usha. You are going to share your slides.
Firstly, thank you very much, Dr. Shaw, for inviting me to share today. And thank you to Iris for supporting us on this platform. So, look, this is part of a larger setting. So I'm not going into the basics, but the topic I've been given is, can nutrition help lower dyslipidemia? Now, you've just seen the talk on triglycerides, so I won't linger on that. What I'm going to concentrate on is LDL, because for all practical purposes, if you want to modify your CV risk, then the molecule you need to modify is your LDL. Now, if you want to think about modifying diet through LDL, remember, whilst you have the NPC1 that actually facilitates transfer of dietary cholesterol into the cell, there is an equal efflux again into the intestinal lumen through these receptors. Part of it then gets absorbed as chylomicrons, nascent chylomicron particles into the limbs, where it goes to the liver. And in the liver, the level of chylomicron can act as a brake on the HMG-CoA reductase. So you could argue that if you increase your dietary cholesterol intake, why doesn't the endogenous cholesterol manufacture just go down? And why don't we then just see some kind of an equilibrium? Unfortunately, this mechanism to the right of the screen is not a good brake on endogenous cholesterol manufacture. So then I asked myself a few questions. One, is there a correlation between dietary and blood cholesterol? So does it matter if you eat pure cholesterol or if you take in a lot of cholesterol in your diet? Does it automatically mean that there is a higher blood cholesterol? The answer again lies in these two mechanisms. This is why I'm showing you this slide. The efflux from the cell and the brake on your cholesterol manufacture by inhibiting HMG-CoA reductase here. And we know that statins act on HMG-CoA reductase. So that's an enzyme we are familiar with. Well, this is the results. One of the studies I'm showing you from epidemiological studies and meta-analysis. Nearly 2 million patients from various studies. Nearly 8,000 patients from the Chinese health survey, another 8,000 Chinese adults, 3 large cohort studies from Europe, Asia, and America, and various nearly 40 prospective cohort studies from all over the world. Effectively, if you look at cholesterol consumption, the cholesterol from an egg is the richest, purest source of cholesterol you can get. It beats red meat. It beats even things like ice cream. So if you want to study cholesterol as a nutrient ingestion, then looking at egg intake is a really good comparison. So if you look at all these studies, there is no association between dietary cholesterol, CAD, or secondary effects. But equally, the egg intake is not associated with a significant change in total cholesterol, LDL, triglycerides, or HDL. So if the amount of cholesterol you eat doesn't significantly increase your cholesterol level, can reducing your cholesterol intake significantly lower your cholesterol level? That's the question you've got to ask yourself. Lowering your cholesterol intake may alter your plasma triglyceride levels and may, in the Chinese population, improve your HDL level, but it is not associated with an improvement or deterioration of your LDL and total cholesterol. Now, okay, that's eggs. Well, what about the effect of various foods on LDL cholesterol levels? If I look at eggs, we've said not a huge amount of difference, the purest form of cholesterol. Well, let's look at the other foods. So this is a slide showing you various PUFA, MUFA kind of foods. And you can see the common ones that we prescribe: flaxseed oils, fish, turmeric, nuts, green tea, ginger, berries, garlic, all these things that we tell our patients help a lot. Look at the reduction, they say, is small to moderate. Look at this small to moderate as a number, because what we have seen and what Dr. Muralidharan has shown us is that you need to make a significant difference to your LDL to actually make a difference to outcomes. So there are some food substances that can make a small to moderate reduction in your LDL cholesterol. This is LDL. So it depends. Now, this is the strength from the same study. The smaller the circle, the smaller the number, and the lighter the evidence. The larger the circle, the stronger the evidence and the more the numbers. So things like soluble fiber, flax seeds, whole grains and fiber, and soy and some fish have a reasonable effect in terms of lowering your LDL cholesterol. So then the question is, okay, we've seen that there are some foods that make a small to moderate difference. But if I modulate, if I change the macronutrients, will that make a difference? Well, in this, they did a crossover trial where they looked at a high carb, high protein, and a high fat diet. And you'll see that these are all the breakdown or the molecules along the cholesterol biosynthesis pathway. Just look at the total cholesterol. There is not a huge amount of change from time 0 to 6 hours post high fat, high carbohydrate, or high protein meal intake. It doesn't make a huge amount of difference. So whether you do a high fat, high protein, or a high carbohydrate. However, what this study showed was that with a high fat diet, there is a transient about 4-hour decrease in your endogenous cholesterol biosynthesis, not enough to make a huge difference. Then you look at strategies, treatment strategies, and diet. This is what I want to draw your attention to. This number, even Dr. Muradharan mentioned, that to make a difference, to reduce your relative risk by even 15%, you need to reduce your LDL cholesterol by about 38.7. So 1 millimole or 38.7 milligrams per deciliter will give you a small reduction in your CV outcomes. But if you want to reduce your risk by 50%, you need to get your LDL down to less than 2, down to 1.8 in fact. Given that scenario, keep these numbers in mind. 2 to 10 grams of dietary fiber reduces your LDL-C by 2.2 milligrams per deciliter. Remember, we are all starting, if we are healthy, by around 120 to 140. Phytosterol by 13. Nut consumption, and you need 67 grams of nuts daily to reduce it by 10. And a Mediterranean diet by 10% after 5 weeks. So let us assume you have somebody who has an LDL of 180. They want to make dietary changes. What can they do to bring it down to 100 or even 70 for a high-risk patient? A Mediterranean diet, 10%, 18 to 20 milligrams reduction. They start at 140, it's still only 14 milligrams per deciliter reduction. So with a diet, it is extremely difficult. Then people will say intermittent fasting. Well, 1 to 2 meals up to 5 to 6 small meals a day. Your LDL reduction is about 2.65. HDL goes up by about 1 and triglycerides by about 1.6. So from baseline, it really doesn't make such a lot of difference. Even if you do the best diets, it's about a 5 milligrams per deciliter difference. So intermittent fasting doesn't work. Reduction of macronutrients doesn't work, and reduction of individual components doesn't work. What about fruit and vegetable and high fiber? Well, the type of food, number of times in a week that you consume it, look at your difference in LDL cholesterol, about 4.6 to 5. Your LDL-C, total cholesterol, LDL-C about 3, and your HDL goes up by about 1 to 1.5. So no matter what you do, fruits, nuts, fiber, vegetables, micronutrients, difficult. This is a very good paper going back almost 3 decades in the HDL, in the NEGM. And what they looked at was baseline values for risk factors for CHD and changes at 1 year according to exercise, diet, or diet plus exercise. Look at their LDL. If you do just exercise or diet, it goes down by about 5.6 to 7.3. And this is the sum total after 1 year. Most of the diets actually show you reduction over anything from 6 weeks to a few months to a year. So given that this is the scenario, your diet affects only about 20 to 30% of the cholesterol in your blood. The rest is endogenous circulation. Number 2, decreasing your consumption of saturated fat to less than 7% and your total daily calorie intake. of your total daily calorie intake can reduce your LDL by 8 to 10%. 8 to 10% if you start at 180 or 140 is absolutely inadequate for any kind of a cardiovascular risk reduction. Remember the slide I showed you, 50% risk reduction or less than 2.2 down to 1.8 to get any kind of a meaningful CV risk reduction. And most of the studies, please remember, are done in healthy individuals with an isocaloric or hypocaloric diet in whom weight is maintained, and you don't take into factor the daily life, the weight gain that we go through over decades. So trying to maintain an LDL with just a diet is really difficult. And whilst I'm not discounting the importance of a diet, we still recommend that they need to have a diet that is low in saturated fatty acids, low in added sugars, low in added cholesterol intake. Diet alone, as you would have seen, is simply not enough to make any meaningful differences to your total LDL level. I'm going to stop sharing and hand back to Dr. Shaw.
Thank you, Dr. Usha. The time given to you was only 10 minutes to cover up on a dietary or nutritional advice. So that's a big challenge. I hope someday we can take up again. And you highlighted a beautiful paper on a summary of an egg consumption, which was probably more assuring. The simple question, people equate a cholesterol or a blood fat with kind of an oil or a ghee which is consumed. So we have that important question that in couple of lines, Dr. Muralidharan, how you will have to unmute. How do you advise? I am sure people ask you at the time of any coronary event what kind of an oil and how much quantity of an oil. In which kind of a language you advise to the people, though they automatically change on their own after an intervention. Before we come back to Usha, who can take some voice rest for a couple of minutes.
Yes, sir. What I do in my practice is like, particularly you said, you put the context very simple, like people with acute coronary syndrome, recovered, we have done some procedure, about to leave, counseling the family. This question is often asked. Luckily, I am in university hospital settings where a lot of departments, we do involve physician, diabetologists. We have a dietary department also who help us in a big way in these things. But from our side, we say, avoid saturated fats. So our ghee, other things, number one. Encourage more of POFAs or monounsaturated things. We recommend them to avoid, plain sugar, these things. And what we try to tell them is like, unlike the West, not every one of my patients are affordable for a virgin olive oil, other things and all. We have what the oil available in our settings. We try to recommend them to use with the lesser things. Common things that our friends you recommend is like sunflower oil, rice bran oil, or sometimes palm oil. I would like to listen from Dr. Usha also what other oil she will recommend. But my recommendation to my patient is use the oil as little as possible, number one. Number two, never reheat the oil, number two. We know that when you reheat, it loses the whatever the beneficial little it has. So lesser the oil as least as possible, and do avoid reusing the same oil. That is straight away tell them not to use hotel foods, because most of the hotels, most of the roadside restaurants, they reuse the oil. So we tell that to them. These are two things I make comment. And regarding they pester on ghee and other things, I used to tell them like that, occasional vacation is allowed. If they go for some function somewhere, for 1 spoon, I say, please, but remember, it should be very, very occasional, not a daily one, not to appear as a patient in front of a crowd. But remember to check your lipids, we'll watch it. That's what I say, sir. Well, love to listen from Dr. Usha and learn from both of you.
Thank you, Dr. Muralidharan. Usha, we have to close in 3 minutes time. So,
Done.
Simple. Now we are moving to ADA recommended diet and an ideal diet for diabetic people where carb has to come from 50% carb. Rest of the calories, people can't consume so much protein. So fat calories get pushed to 30%. So what kind of a fats they can increase so that they are still into 30% and they are into recommendation. And the last question is on a portfolio diet. which was published a paper in circulation. If Dr. Muralidharan has read, there was a paper in circulation a couple of months back on a portfolio diet. Yes, Usha.
So, number one, I think the type of fats are less important. I'm saying less, not important, rather than the absolute amount of fat, number one. The reason I say this is because in most of our diets, we exceed that 30% quite easily. And I think what the most important thing is to cut it down. Yes, we can get fats, but healthy fats from nuts, from dairy. We can always opt for the polyunsaturated fatty acids rather than this. In cooking and added fats, we must try to reduce. The recommendation is 450 grams per person per month, or 1 tablespoon, roughly speaking, per day of added fats. If we can stick to that and then get our healthy fats from nuts and dairy and other sources, then that's one good way of managing. The second thing is, people will ask us, can I use cold pressed oils? Can I use groundnut oil, olive oil, mustard oil? I think our rice bran oil, sunflower oil are healthier along the spectrum. Cold pressed lightens your pocket, not your cholesterol levels. And if you're going to, well, ghee is one of those things where no matter how much we'll tell people that it is saturated fatty acids, they insist that it's part of their diet. Then I tell them to keep it to less than, ideally, half a teaspoon or so per day, and to take into consideration that it's part of their overall requirement of 1 tablespoon per day. Sorry, what was the second bit of the question? So
portfolio diet circulation paper.
Yes. So the portfolio diet
is closer to Mediterranean diet. So probably they have looked at various diets for a cardiovascular health. We would leave it right now for future episodes on Krivast Academy. Whatever Dr. Usha highlighted was fairly sufficient. We would not be able to satisfy the appetite of listeners if they were looking for extensive data and information on dietary intervention. So Dr. Usha, you did a great job in covering up in 10 minutes. And with this, I would thank Dr. Usha, Dr. Muralidharan as an experts today. I would thank all the listeners for joining this Saturday evening. And I would thank Aries to allow 3 of us to have a dialogue and discussion on an important subject of managing LDL cholesterol. With this, I would hand over to Dr. Hiren. Thank you, Doctor.
Thank you, Dr. Sanjeev Saha, sir. Thank you, Dr. Muralidharan, sir, and Dr. Usha ma'am, for serving an excellent scientific feast today. Not only on the lipid part and maybe in the diagnostic or triglyceride part, or maybe LDL cholesterol part, but also very important the nutritional part is what Dr. Usha has delivered talk on that. So with this, I think we learned a lot from the today's session number 8. And as Dr. Sanjeev has mentioned, we would like to emphasize further in maybe in the future session on the nutritional part and how it's going to be helping the dyslipidemia management. So I think with this, we are going to close this meeting. I would like to thank you each and everyone. And also I would like to thank you all the participants for your wonderful hearing for today's session. Thank you all. Good night.
Thank you all.
Good night, ma'am.
Thank you. Good night. Good night.